Good evening, ladies and gentlemen, and thank you, Dr. Ruturi, my good friend and colleague, for the kind introduction. And I would also like to take this opportunity to thank the organizing committee of the Kenya Renal Association for inviting me to speak at this very educational forum. And we've so far had very excellent speakers and presentations. So I've been asked to talk on salvaging vascular access. So to start off this topic, um, current literature and guidelines recommend that an AV fistula to be the preferred type of vascular access for hemodialysis. AV fistulas, once they have been established, have longer patency and lower rates of complications compared to AV grafts and catheters. And with the increasing proportion of patients on hemodialysis, the rate of failure to mature has increased with a decrease in patency rates. So access thrombosis accounts for 65 to 85% of cases of permanent access loss. And AV access thrombosis leads to multiple missed dialysis sessions, inpatient admissions, and placement of temporary dialysis catheters. Fistula complications are associated with morbidity, mortality, and the high economic burden. Now, an AV access is a patient's lifeline. Hence, all efforts must be made to salvage the access. The value of salvage procedures for AV fistula dysfunction and complications has been well established in different guidelines. Thus, those in charge of vascular surgery must have the knowledge and skills necessary to salvage an AV fistula that is failing, has thrombosed, or is threatened by any other complications. Now, one very important thing to know is that an AV fistula is a continuous circuit. It's not just an anastomosis between an artery and a vein. So blood flows from the heart through the arteries, through the anastomosis that the surgeon has created, and returns via the peripheral vein, which is now the cephalic vein or the basilic vein, into the central veins, which are axillary, subclavian, innominate, superior vena cava, and finally into the heart. So this is a whole circuit. So whenever you examine a patient, you don't only just examine the AV fistula site that has been made. Examination should not only be limited to that site only, and it should also include the remaining part of the arm, shoulder, breast, neck, and face. Now, to create a good mature fistula that is functioning, one has to cross a hurdle, and that's the fistula hurdle. So there has to be early referral by the nephrologist, fistula placement by the surgeons, and then fistula maturation, which takes at least 6 to 8 weeks. And then thereafter, fistula cannulation before you have permanent, reliable hemodialysis access. So the challenges in creating a successful fistula are challenges in planning, challenges in maturation, challenges in maintaining. So in terms of planning, there has to be a timely creation of an arteriovenous fistula or a graft. And for this, the patient needs to be referred to the surgeon when the patient is in CKD stage 3, stage 4. Now, challenges in maturation are overcome by, you need to overcome poor maturation and early failure. And in maintenance, early detection of AV fistula dysfunction, proper cannulation, and proper patient education to make them understand that these fistulas require maintenance and they need to understand that they have to come for these procedures. Now, complications of AV fistulas are new AV fistula complications or established fistula complications. In the new fistula complications, the biggest complication is non-maturation. In established fistula complications, it can be divided into thrombotic and non-thrombotic complications. Now, primary maturation failure in fistulas occurs in 20 to 60%, and that's quite a high rate. And this is either due to patient factors, the vessel factors, or gender factors. So in patient factors includes diabetes, poor cardiac function, aging population, obesity. Vessel factors are usually because of unsuitable vessels. They are too small or they are calcified. So the minimal luminal diameter that you require to make an AV fistula, the artery has to be at least 2 millimeters and the vein at least 2.5 millimeters. There has to be good vessel distensibility, Arterial stiffness and resistive index also play a big role to decide if this fistula is going to mature timeously or not. Females have smaller arteries and veins, hence they tend to have slightly higher rate of maturation failure. Now, established AV access complications can be thrombotic or non-thrombotic. The non-thrombotic complications are aneurysms, pseudoaneurysms, distal ischemia, venous hypertension, median nerve injury, heart failure, seromas or lymphocytes or infections. But most importantly, any access complication leads to loss of access. So you need to address these complications so that you don't lose the access. So why does stenosis develop in an AV fistula or a graft? So it's mainly due to neointimal hyperplasia. And in an AV graft, it's mainly at the venous anastomosis. In an AV fistula, the arterial part is the inflow, so the stenosis develops at the anastomosis, or on the venous side, which is the outflow, it develops in the tract of the vein. Now, central venous stenosis also develops, and it's very high with subclavian catheters. It's also increased with the number of central catheters that are placed. Stenosis needs recurrent intervention to maintain patency. So it's not one of those things that if you angioplasty a fistula once, it's going to be fine forever. Thrombosis due to poor progression of stenosis, and thrombosis occurs more in grafts compared to fistulas, and the reason being that grafts do not tolerate very low levels of blood flow. Fistulas can tolerate extremely low levels of blood flow and don't thrombose as quickly as grafts. Now, with each thrombotic event, the chance of survival of the access also reduces dramatically. So worsening stenosis causes reduced blood flow. Reduced blood flow will cause thrombosis, and that eventually leads to access loss. So common sites for stenosis in an AV fistula or an AV graft. In an AV fistula, it would happen at the arterial anastomosis. It can happen at the swing site. The swing site is defined as the segment of vein that is mobilized for us to do the anastomosis to the artery. The needle cannulation segment, the cephalic arch segment. The cephalic arch joins the axillary vein at the level of the shoulder. So that's the cephalic arch segment. Stenosis do develop there. Then central thoracic veins, or if a stent has been placed, at instant stenosis then. In an AV graft, the commonest site of stenosis is at the vein graft anastomosis. You can get stenosis within the graft, the body of the graft itself, especially at the needle cannulation sites when fibrous tissue grows through the needle holes into the graft. You can get stenosis of the central veins, stenosis at the arterial anastomosis, or if a stent has been placed previously, instant stenosis is also possible. So swing site is a segment of vein that's mobilized for arterial anastomosis in the creation of an AV fistula. So in a cephalic vein, it can happen when we create a radiocephalic or a brachiocephalic AV fistula. In a basilic vein, it can happen during transposition from medial to a lateral position. So stenosis happens in the vein at different sites. So the commonest is at the venous anastomotic site, in the peripheral vein, inside the graft, central veins, and sometimes multiple locations. You can have a stenosis at the anastomosis, within the graft, and the central vein stenosis as well. Now, reasons for an AV fistula failure and graft occlusions are divided into inflow problems and outflow problems. So inflow problems are arterial. This is anastomotic or juxta-anastomotic narrowing, or stenosis of the inflow arteries. So stenosis or occlusion of the subclavian or axillary arteries. And outflow problems are mainly venous. So venous problems happen at venous anastomotic sites, stenosis within the vein at the needle punch sites, at the cephalic arch where the cephalic vein joins the axillary vein, or central venous stenosis. That leads to an outflow problem, venous outflow obstruction. So when examining a fistula that's failing, there'll be a reduced thrill. The arm elevation test will be positive. So like in this diagram, this guy has a radiocephalic fistula, and when the hand is down, the fistula fills up. When the hand is elevated, the fistula collapses. That basically means that there is no significant stenosis in the fistula tract. There's arm swelling or collateral vein development with failing AV fistulas and venous outflow obstructions. There's high venous or arterial pressures and the low clearance as represented by the low KTV. So when we suspect stenosis clinically, we send the patient for an ultrasound. And on ultrasound, you can see the stenosis in a B mode, or the color Doppler, you would see that there is high peak systolic velocities, and there's marked aliasing, like you can see in the first picture over here, this mixing of color where you see red, blue, yellow, orange, all of that is called aliasing. And there's marked aliasing when there's a high-grade stenosis. In this image in the middle, you can see that there is a stenosis that has developed. And on a CT angiogram or a venogram, this is a patient who's had a brachiobasilic AV fistula, and you can see in the midsection of the basilic vein, there is a tight high-grade stenosis. So management of failing AV fistulas is done by angioplasties plus or minus stenting. The access usually is from an arterial side. Usually we choose a radial artery if there's a good pulse, or we go straight through the AV graft. An angiogram is done as you can see in the middle picture, and you can see the high-grade stenosis in the vein. So we cross the lesion with a wire, hydrophilic wire, and then we angioplasty. So the balloons that we use are high-pressure balloons. High-pressure balloons are needed in veins to break down the fibrous tissue. High-pressure balloons cannot be used in arteries, otherwise you rupture the artery. But in a vein, a high-pressure balloon works very well because of the fibrotic nature of the stenosis. So that's a balloon with the inflation device. And then you do an angioplasty, and you can see that the stenosis is cracking. Inflate the balloon for at least 2 to 3 minutes, and a completion angiogram shows resolution of the stenosis. This is a patient who has a radiocephalic fistula with a very weak thrill, and the angiogram done through the fistula shows a very high-grade stenosis at juxtaanastomotic stenosis. So we finally cross the lesion, angioplasty it, and that's the final result, showing good flow into the fistula as well as the artery. So this is a patient who has a brachioaxillary graft. So graft made between the brachial artery and the axillary vein. And in AV graft, stenosis develops at the venous anastomotic site, and it's going to happen in almost all the patients. It's just a matter of time. An angiogram shows that there is a very high-grade stenosis at the venous anastomotic site. Angioplasty is done, and after angioplasty, there is recoil of the area that was treated. So we stented it. That's how a stent looks like, a bare metal stent. And that's the final result with good flow back into the central circulation. So with thrombosed AV grafts, this is the patient who's got a forearm loop graft, which is between the brachial artery and the basilic vein. Thrombosis occurred a week ago, and we cannulated the graft and declotted it using Altiplase TPA. And after declotting, we take an angiogram, and you can see there's still some residual clot over there. So we continue giving the TPA, and after this good flow into the graft, we angioplasty the entire graft. So angioplasty over there, and at the venous anastomosis, this is where the graft is anastomosed to the basilic vein. After that, there is excellent flow in the forearm loop graft. However, so this is the venous end of the graft, but just distal to the venous end, there's a long segment of diseased vein, basilic vein. So angioplasted that as well. However, there was still recoil at that segment. So we decided to stent that segment, and this is flow into the outflow tract. Declotting can also be done by open surgical technique, whereby you make a small incision over the graft and isolate it. As you can see in this image over there, just like 1 or a maximum 2 centimeter incision. Put a radial catheter in, radial sheath to do the angiogram. And on the angiogram, you can see that's a radial artery, ulnar artery, and that's a brachial artery. And that's the area of anastomosis with no flow going into the graft, into the brachioaxillary graft. So after graftotomy and thrombectomy of the graft, repair the graft and repeat the angiogram, and you see there is excellent flow of blood into the graft. However, as we have said, the stenosis always occurs at the venous end of the graft. So that is angioplasted, and thereafter you have good flow into the graft. So this is the patient who had a thrombosed radiocephalic fistula, 24-hour history. So we entered via the radial artery, finally crossed into the fistula, lysed it with the TPA, and repeated the angiogram. That's the angiogram after TPA, and you can see the juxta-anastomotic stenosis at the swing site. So that was angioplasted, and we also went and angioplasted. We actually went further into the cephalic vein and also did an angiogram all the way into the central thoracic veins to ensure that there's no stenosis. However, so post-procedure, there was excellent thrill in the fistula, but the following day there was no thrill. So we did whatever had to be done. We lysed the thrombus and we angioplasted the culprit lesion, and there was no other lesion that could have caused thrombosis, but however, it still thrombosed the following day. It's one of the reasons why we are now moving away from trying to either do a thrombectomy or thrombolysis of the AV fistulas once they have occluded. So in thrombosed AV fistula, there is absence of bruit or thrill using auscultation and palpation throughout systole and diastole, at least 8 centimeters proximal to the arteriovenous anastomosis. It's usually a futile attempt. Trial can be done for those who get occlusion less than 24 hours. And the thrombus actually destroys the endothelium and makes it more thrombogenic. So even though you do your declotting via a thrombectomy or a thrombolysis followed by an angioplasty, your success rates are still very, very low in thrombosed AV fistulas. We are actually just abandoning them once they thrombose. Now, the balloons I talked about are plain balloons, and they are actually high pressure balloons. There are drug-coated balloons as well. Now, the advantage of drug-coated balloons, so they are coated with a drug called paclitaxel, which reduces smooth muscle proliferation within the stenosis. So in a study that has been done by Medtronic, using drug-coated balloons, there is a significant target lesion primary patency of anything between 20 to 25%. Even access circuit primary patency is much higher with drug-coated balloons. This basically means that if angioplasty has to be done like every 6 months to 12 months, you'll probably prolong that to about 18, 24 months. Another complication that can actually threaten an AV access is aneurysm formation. So an aneurysm is a diffuse and progressive degeneration of the vascular access site, and the patient has signs of either bleeding, infection, or ulceration. And it happens from repeated cannulation in the same area of the fistula. That's a buttonhole approach where 2 segments are chosen and we always cannulate those segments. Aneurysm formation can be reduced if not prevented by changing the position of the needle insertion sites, and that's a rope ladder approach. So this is how aneurysms look like in long-standing fistulas and the areas which have been needled repeatedly. So if you look at it, a mature AV fistula is between 6 to 12 millimeters in diameter. An AV graft is about 6 millimeters in diameter. It will never grow more than that. And there's imminent aneurysm rupture when the aneurysm is 4 to 5 times the size of a mature fistula. And aneurysms, once formed, because it is degenerative in origin, will always continue to grow. And rupture leads to death from torrential bleeding. So urgent repair is indicated when the aneurysm is more than 4 to 5 centimeters in diameter. Emergency repair needs to be done when aneurysms cause skin necrosis. And pseudoaneurysms need to be repaired even earlier as they rupture at smaller diameters. Pseudoaneurysms can cause AV fistulas or AV graft loss by compression and thrombosis. So the treatment of aneurysms and pseudoaneurysms with a view to salvage the fistula is essentially surgical. So surgical resection and replacement with an interposition prosthetic graft is a good way to do it. Now, vein grafts are too small because the native vein diameters are like 3-4 millimeters, and very rarely would you even find a 5 millimeter vein to use it as an interposition graft. And you're putting a 3 or a 4 millimeter vein and connecting it to a fistula that's already maybe 10-12 millimeters in diameter. So it will take very long for that vein to mature, and probably as the fistula is waiting to get to that area of the vein is waiting to get matured, it may even occlude because it's actually a stenotic segment if you look at it in relation to the rest of the fistula. Aneurysmography is also done. So we expose the aneurysm, control the fistula, open the aneurysm, trim the edges, and then close it longitudinally. Now, if a fistula is very tortuous, then you can do primary repair. So you resect the aneurysm and you can mobilize the segment of the fistula proximally and distally and bring the ends together. Endovascular treatment doesn't really have a role in aneurysm and pseudoaneurysm management because the aneurysms occur at needle puncture sites. So if you put a stent graft there, a stent graft is a covered stent. There's a material that covers it. It's not a bare metal stent. Now, if you put a stent graft where the aneurysm is, and it is actually a needle puncture site, you would actually damage the stent graft and cause it to thrombose, and thrombosis would lead to loss of that fistula that you're trying to salvage. So this is a patient who has a pseudoaneurysm. That's how it looks like intraoperatively, and after resection, we put in a 6 millimeter PTFE graft. Another complication that can threaten your AV fistula or graft is venous hypertension. So high pressure in the veins due to damage to the venous system, often presenting with arm and hand swelling, dusky color of the hand, and dilated veins on the arms or chest wall. So the reasons for developing venous hypertension is side-to-side anastomosis between the artery and the vein, stenosis in the fistula vein itself, or central venous stenosis from previous neck catheters, especially subclavian or internal jugular. It presents as multiple collateral on the chest wall. You can see these veins over there. There's massive arm swelling, and there's evidence of multiple catheters.
Sit up.
There's a face, neck, and chest swelling as well. When the subclavian, the superior vena cava is involved, you can see facial swelling, multiple catheter sites. And the patient who's had an AV fistula on this arm with swelling of that arm and
So just give me up an hour. You
multiple collateral veins. Same thing, catheter on the ipsilateral side of the fistula, massive swelling of the arm. So clinically, there's arm swelling that is worse during hemodialysis. There's inability to form new AV accesses on one or both arms. There is inadequate hemodialysis with high venous pressures, and there's prolonged bleeding from the puncture sites. Diagnosis is usually made by CT venography. So clinical suspicion is there, but diagnosis has to be made by a CT venography. And on the CT venogram, you would be able to see stenosis, for example, like that is in the brachiocephalic vein, that is in the right brachiocephalic and left brachiocephalic, and narrowing in the superior vena cava. On this section, there is a complete occlusion of the left brachiocephalic and almost a non-existent superior vena cava. So after getting access into the vein, you try to cross the lesion. The most difficult part is crossing the lesion, which may require use of multiple catheters, multiple wires. But once you've crossed, then angioplasty is done. Single balloon followed by double balloon, because we don't have diameters of more than 12 millimeters, and we would probably want to reach diameters of at least 16 or 18 millimeters when we are looking at the innominate veins and the superior vena cava. So that's a double balloon technique. One has been introduced from the left internal jugular. The second one has come from the femoral vein. And after that, there is flow into the brachiocephalic and superior vena cava. And the results are quite good once the outflow obstruction has been sorted out. This is reduction in arm swelling that is seen 2 to 3 days after the procedure. So like massive arm swelling there to almost nothing there. This patient's arm as well, this was prior to the intervention and this is after the intervention. This is the patient who had superior vena cava syndrome. She's got complete facial swelling, neck swelling. She can't even open her eyes. And after the angiogram shows that she's got a very high-grade stenosis, probably 1 or 2 millimeters. And after dilatation, she's much better 2 days down the line with much marked reduction in the facial swelling. Similar patient who has facial swelling, this is the superior vena cava, and this is the azygous vein. So this is the supra-azygous part of the superior vena cava. This is the infra-azygous part of the superior vena cava. So basically this vein divides it into two. Now there's a stenosis at the junction of the superior vena cava and the right atrium. And that is causing the patient to have arm swelling on the side of the fistula. So dilatation with 2 balloons and a complete opening up of the superior vena cava was done. This patient has a complete occlusion of the superior vena cava. That's the left brachiocephalic vein. This is the azygous vein, which looks almost like an superior vena cava. That was crossed with a lot of difficulty, and a stent, a 20 millimeter diameter stent, was then placed in. So similar patient, fistula on one side, breakdown of the wound, difficulty to cannulate. So an angiogram done shows a complete occlusion of the left brachiocephalic vein. Angioplasty done, followed by a stent. Flow into the stent can be seen over there, and then thereafter, a week down the line, is complete resolution of the arm swelling. Now, usually with central veins, angioplasty alone is not a very good option. There will be recurrence within 6 months. So if you're doing angioplasty alone for the central veins of the neck, 6 to 9 months, you'll have to keep repeating it. With the stent can give you at least 18 months. So massive arm swelling again. Angiogram shows, or rovenogram shows, a focal occlusion, like a band in the left brachiocephalic vein. Angioplasty done and stent, followed by a completion angiogram that shows a good flow into the right atrium and resolution of symptoms. Similar patient, previous catheter on the same side, a very, very good AV fistula on the right arm, a brachiocephalic fistula. However, the nurses are not able to cannulate it because of the massive arm swelling. So angiogram done shows a complete occlusion of the brachiocephalic vein across the lesion. Angioplasty did, and then there is complete flow. So these are 2 wires you can see over here. That's because we used 2 balloons to reach a diameter that we thought was good enough as an outflow diameter. 1 week down the line, you can see that arm, and you can see her sitting outside with it's almost the same size as the left side, if not just slightly bigger. So patients who've got pacemakers, pacemaker wires will always irritate the central veins, and a few unlucky patients will end up developing stenosis that is significant. And especially that happens more with the hemodialysis patients because they have a fistula. So if they develop a stenosis in the central veins, the arm swells. So this patient had arm swelling on the right side. She has a pacemaker on the left side. Pacemaker is inserted through the subclavian vein, goes to the innominate and IVC into the right atrium. In this patient, all we could do was an angioplasty. I did not want to put a stent and trap the pacemaker wires between my stent and the wall of the SVC. So we just do angioplasties every 6 months. Now, despite doing stenting, you do develop in-stent stenosis. However, it's much later than stenosis that develops after angioplasty alone. And the treatment is simple. It's cross the lesion and just angioplasty. I try not to put a stent within a stent because you finally reduce the diameter of the residual lumen. So just angioplasty of that lesion gives very good results. Now, hero graft, hero basically means hemodialysis reliable outflow obstruction. So hero graft is can also be used to salvage an AV access, and basically we cannulate the central vein. So from the internal jugular vein, we are able to put in a catheter that goes into the right atrium. However, the prerequisite is that the SVC has to be patent, otherwise you will not be able to use this. And it has a detachable segment that is connected to a prosthetic graft, and the graft is anastomosed to the artery. So all this is tunneled, and this is tunneled as well. However, we don't have this in our setup. Ischemic steal syndrome is another complication that can harm an AV access, whereby the fistula diverts blood from the distal circulation, resulting in a zone of arterial insufficiency in the tissues distal to the fistula. So like you'll end up having coolness in the hand. So blood is going from a brachiocephalic fistula, blood is going back into the fistula rather than going down to the hand. And it happens in about 20% of upper limb AV fistula, but majority are asymptomatic. Those who are symptomatic, I've seen they have significant radial or ulnar artery atherosclerosis. So these are like very old patients. I've never seen steal syndrome in young patients who've got very good palmar arch as tested by the Allen's test. And they present with paresthesia, coolness. However, the pulses are retained. It becomes a surgical emergency only when the pulses are absent or there's gangrene of the fingertips. There's a grading system for that. Stage 1 is coolness of the hand only. Stage 2, they may have some pain in the hand during dialysis. Then stage 3, they have rest pain. And stage 4, they have ulceration, gangrene, or necrosis. Now, treatment of distal ischemia to salvage an AV access is basically done by a few procedures. You can put a band on the AV fistula to narrow how much flow goes into the fistula so that quite a bit of the flow can be directed to the hand. Now, the only problem with this is that you have to know what size of band to use. You have to have pre-banding volume of blood that's going into the fistula and be able to assess post-banding flow of blood into the fistula. So that's the only technical part of it. The ones that I'm used to is doing a bypass graft. So you can do a graft between the brachial artery and the radial artery, and then ligate the artery distally. So the blood goes from the artery, it goes into the bypass graft, and it goes to the hand. Blood also goes from the artery into the fistula, and then you ligate it distally. That's called a distal revascularization. We were revascularizing distally, and interval ligation. We are ligating the artery. Or you can do a Rudy procedure, which basically means revascularization using distal inflow. So to get blood into this fistula, this is a proximal inflow, this is a distal inflow. You can do a graft between the artery and the fistula. So blood comes down and then goes reverse into the fistula, and then you ligate the fistula. Or you can do a PI procedure, what is called the proximalization of the arterial inflow. So like with the brachiocephalic fistula, the anastomosis is in the elbow. You can take down that anastomosis, do a graft, and reconnect the anastomosis higher up in the brachial artery, close to the armpit. So basically, this is now your inflow into the graft rather than that, and then you ligate the fistula. If nothing else works and you have distal ischemia and you have necrosis of the hand, fingers, or whatever, then ligate the fistula and save the patient's hand then. Infections can also compromise an AV fistula, and this could be local vascular infections or access-related sepsis. It could be bacteremia or a combination of all of this. So antibiotics are given, incision and drainage of the abscesses are done, But for AV grafts, if an AV graft gets infected, that's actually a disaster because you have to surgically remove the graft. And if it's a forearm graft where it's a loop graft which is connected between the brachial artery and the basilic vein, you're still lucky because wherever the venous anastomosis was going to the basilic vein, um, you have you can have you can use the basilic vein as a secondary fistula, then like a transposed brachiobasilic venous fistula. So infections need to be treated. If there's an infection and the wound opens up and the anastomosis is exposed, that will actually cause bleeding, and that bleeding can be torrential. If it's an AV graft that is uh, infected, that has to be taken down. Heart failure also develops. High output cardiac failure can be developed, and it's seen more with fistulas as opposed to AV grafts or catheters. And it happens when the fistula flow is more than 20% of the cardiac output. Treatment is by banding, or you can like gate and abandon the fistula. So in summary, an AV access is the lifeline of a patient, and do whatever it takes to salvage it, or else there will be loss of access for reliable hemodialysis. And there's no permanent access. We call it a permanent access, but eventually all types of dialysis accesses become dysfunctional with time. Stenosis remains a common problem for access failure. And to avoid venous outflow obstruction, which is a big problem that we're seeing, don't place in subclavian catheters. If you do place in tunneled neck catheters, they should not stay in for more than 3 to 6 months to reduce the chances of developing central venous stenosis. Access planning, monitoring, timely and appropriate intervention should remain an important part of access care. Thank you very much for your attention.
Dr. Gill, can you hear me?
Yes, Doc, I can hear you.
Okay, thank you very much for an excellent presentation. You actually make these interventions look easy, but you and I know how many hours you take standing in the cath lab
It takes
trying
quite
to
some
get
time,
this
yeah.
done. Yeah,
Yes,
putting
true.
those wires in and getting those access. But I like the choices, the selection you made of the various things we face and how we try to
Yes,
solve them. I've actually quite illustrative to our colleagues so they know that these techniques are available locally and we're able to salvage
yes,
the fistulas. Again, coming back to what I was saying earlier on about how it has to be a philosophy of attempting to salvage these fistula, and
yes,
it has to be the direction we take. Uh, Clearly, as physicians, we have to talk about prevention. So, of all these complications, I would like to make a comment on how we can prevent some of them. We talked about stenosis. I think at various meetings, since you and I started attending the meetings, we came to an agreement with at carry meetings that we should all avoid subclavians now, unless you really have no
yes,
choice. But we should avoid subclavians because we've seen the complications of central stenosis, and that's become more and more apparent as we've done more and more angiograms, and we're able to visualize this. Maybe you can make a comment on preventing thrombosis. I know that's probably not possible. Then there's the use of the basilic vein. We hardly use it, and those of us who use it don't transpose it. And so what you find is, I always talk to my colleagues and I tell them you must provide a fistula that the nurses will have. You have to think about the end
yes,
user. How would they use it? And so making a basilic vein, AVF, that is very short, and then it dips down next to the artery, they almost always come back with pseudoaneurysm because somebody will hit the artery, it's too deep, it's always a struggle. So I think it's a good to talk about the basilic vein and how it's available to us. It's actually I prefer it a lot to a graft because I can always move around the basilic and swing it and bring it up the brachial artery. We talked of TPA. In Mombasa, thanks to the late Professor Abdallah, we were introduced to using urokinase. And one of the suppliers made this available at only 5,000 shillings a vial. We've been able to use it in Mombasa now. The team there is able to use this to salvage the early salvage of ABFs, and that has made life slightly easier for them because I only go there a couple of times in a month. Kindly make a comment also on heart failure, because we get these patients who, again, remember these are cardiorenal issues. Remember the patients who come in and you ask to put in a fistula, and you've seen the patient has had an evaluation, or the patient has just left ICU and they do a fistula, and you and I know that this can be trouble, because patients with heart failure, really, you should avoid having an AV fistula.
Yes.
Otherwise, very good presentation. Thanks a lot.
Thank you. Yes, with regards to the basilic vein, I totally agree that, you see, just making a fistula connecting the basilic vein to the brachial artery, just because they're next to each other, it's not enough, because we have to think about the end user. The vein will mature, but the problem is that the nurses find it very difficult to cannulate the basilic vein when it is in a medial location. So if a basilic vein fistula has to be done, then either do it as transpose it, either as a one stage or as a two stage, whichever one finds it easy. But just doing an anastomosis between the brachial artery and the basilic vein and leaving it to the nurse to handle, I think that one we should avoid. So we should either transpose it in the same operation or come back later after 6 weeks, 6 to 8 weeks, once it's fully mature. The use of subclavian catheters, we've said again and again, we should not use them. Subclavian catheters cause severe central venous stenosis, and we see a lot of them. I see a lot of patients who've got complications of venous outflow obstruction, although we don't get to operate on all of them. So I think that should be, subclavians should actually be phased out. Even keeping tunneled catheters, perm cats in the internal jugular vein for a very long time, and then deciding on a fistula 2 years down the line should also be avoided, because by that time the tunneled catheter has actually damaged one of the central thoracic veins. So when you put a fistula, you'll immediately get arm swellings, and then that requires now trying to open the venous outflow obstruction track. Heart failure patients, if you don't have a good AVF, you don't get a fistula, full stop. Because it's like saying, if you don't have a good engine, then there is no point of changing your wheels. If the EF is low, there's no way that fistula will work, because the pumping starts from the heart going into the fistula. If the heart cannot pump sufficient blood into the fistula and there's reduction in flow velocities within the vein will thrombose. The fistula will thrombose. It may never mature, or if it matures, it will probably just thrombose, because the velocities of blood in it are not sufficient to allow hemodialysis to happen.
There's a question here. How do you balance preservation of residual kidney function and use of contrast in the assessment and treatment of AVF complications? I think they're talking about the use of contrast. Contrast is used in worsening the nephropathy.
I think once you're on dialysis, then I don't think it really matters how much residual renal function you have, because the fistulas are made once you're in end-stage renal failure, or rather are being used while you're in end-stage renal failure with a GFR of less than 10. So even if you're passing a little bit of urine and you are on hemodialysis and you do develop a stenosis within the fistula, and you require contrast, I don't think it's a big issue, because to start off with, most of your urea and creatinine is actually being cleared by the dialysis machine. So I wouldn't consider that as anything important.
There is also talk now at a recent controversies meeting, KDIGO controversies meeting I attended. There is talk now, there's a paper that has come out showing that contrast-induced nephropathy is really not that much of a problem, unless you're really flooding a patient with contrast. So, and we do use generous amounts of contrast when we're in the cath lab, but I can share that paper at a later date with those who are interested.
I think as long as they're well hydrated, and contrast-induced nephropathy should only be in patients who have CKD but are not on hemodialysis. If they're already on hemodialysis, then it shouldn't be an issue. But contrast-induced nephropathy is if someone does not have CKD, a very small percentage gets it, and those who are in maybe CKD 1, stage 1, 2, or 3, I think use of IV fluids is actually more protective than using anything else.
Okay, Doc, it's a very good question. Actually, 2, 3 very good questions. how long should it take before cannulating a fistula after you do an angioplasty?
Oh, immediately.
Yeah, I
You
think
can
so.
actually
I
use
think
it on the
that's,
next
yeah,
dialysis session.
yeah,
Yeah,
yeah. Okay, okay.
immediately.
We need to, somebody makes a comment here, this from Esther. We need to do an audit of accesses. We need our own local review of access and outcomes. They should have different arterial characteristics, kilo formation, etc. I think at the last meeting, the late Professor did present data from the work we had done at Arakan Mombasa. But I think we need to do more, maybe a more nationwide kind of picture on our access. And this goes back to having a registry of sorts. But that's something we can work on with Kenya, you know.
Yes, yes. I think that's true. I think we should all, those who are involved in making the fistulas, we should all just put it together and say we've done brachiocephalic fistulas, radiocephalics, and the approximate outcome of it. You know, like were they used, were they never matured, or did they develop stenosis after 2 years, 3 years? I think things like that. We should just put it together because we don't have our own data.
Yeah, we need to have a registry because I think patients are left to telling each other stories while they're on the machine.
Yes.
So how can we treat pain and numbness of the fingers in the fistula hand? Pain
Okay,
and
so
numbness.
if you only have pain and numbness, so again, that's actually a symptom of steel. So distal ischemia, so it's a symptom of steel. So it depends how severe is it. If it doesn't resolve by itself, then you would have to do those surgical procedures that I mentioned, where you can reduce the size of the fistula by banding, or you can do a bypass to increase the blood flow into the hand. So you can do a bypass from the brachial artery to the radial artery. All those procedures that I mentioned previously. In fact, I can just show it on, where's that slide? This one. If you can still see it over here. So these are the procedures that we can do if a patient's symptoms of coolness of the hand or pain on the hand during dialysis doesn't settle. However, we reserve this for patients who actually have rest pain or ulceration, because they really have to, it's a tough procedure and they actually have to have severe indications. Just pure coolness or slight pain, which doesn't really affect them much, I think we just observe them.
Okay, Daktari, as a last comment, I think you're still in the office and we still have a curfew, I think. So we have to let you go. However, one of the last comments has been from Esther again, Esther Gitambu. She suggests that we should, between Kenya Reno and our support, we should organize for an access seminar, purely seminar on just access and the various things we do.
I totally
I'd like
agree.
to thank, I'd like to thank all my colleagues and Kenya Reno Association for always inviting us. And we are always glad to be part of your team. And Santi Sana and all, and for inviting